Good afternoon, everyone. I'm Catherine Brookman, Associate Director of Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we'd like to thank you for joining us today for this free webinar on workplace violence and harassment reporting and response strategy for home and community care organizations. First, a few administrative details. We're grateful to the Ministry of Labor, Immigration, Training and Skills Development for our funding, which supports the delivery of these webinars, and to our presenters who provide their expertise. This webinar will be recorded, with the recording being made available to you along with the presenter's slides shortly after today's webinar. Please note participant names will not be visible in the recording of the webinar. The format of today's webinar is as follows. The presentation will be given, after which time we have a 10 to 15 minute question and answer period with our presenter. Please refrain from using the raise hand button, as we will not be monitoring this feature or any other meeting reactions. During the question and answer period, we ask that you type your questions into the chat. The chat feature can be pulled up on your screen by selecting the chat button in the control panel that appears near the bottom of your screen. I will relay these questions to the presenter or a similar question should we have duplicate themes. Your video is disabled and you will be muted for the entire presentation to ensure there is no background noise disruption. Should you have a pressing question, however, such as a technology glitch which cannot wait until the end of the presentation, please type this into the chat and we will do our best to address it right away. After the webinar, you will be sent a link to an evaluation. Please fill this out, as it will help us in the future delivery of our webinars. Thank you so much for joining us today, and if you have not already, please check out the MSD Prevention Guideline for Ontario website at msdprevention.com. We have just added the Ergo ROI calculator, or the Ergonomics Return on Investment Calculator, which is a free web-based tool to help practitioners estimate the potential financial benefits of ergonomic interventions before implementation. Also, if you are not currently a member of our community of practice for client-patient handling and are interested in joining us, please check out Join the Community of Practice link that's accessible on the CRE-MSD website from the home page under the navigation setting Communities of Practice. Now, it is my pleasure to have Dr. King speak about workplace violence and harassment reporting and response strategy for home and community care organizations. Workplace violence is a contributor to MSD development. We are pleased to let you know that CRE-MSD, in partnership with the National Safety Council, are developing a poster that outlines how workplace violence and MSDs are connected. The following slide in front of you outlines the key components and what this poster will cover. Please watch the MSD Prevention Guideline for the forthcoming poster. Now it's my pleasure to introduce to you Dr. Emily King. Dr. Emily King is Director of Research at VHA Home HealthCare, where she leads research to improve care for home care clients, enhance provider safety and work-life quality, as well as support a more connected health system. Trained in mechanical and biomechanical engineering, her research focuses on home and community care safety, senior mobility and independence, and accessible built environments. She holds multiple patents and has contributed to assisted technologies for toileting, mobility, and safe patient handling. Dr. King holds a master's and a PhD from the University of Toronto and a bachelor's in mechanical engineering from the University of Waterloo. She is an assistant professor in the Division of Occupational and Environmental Health at the University of Toronto's Dalai Lama School of Public Health and an adjunct assistant professor at the University of Waterloo School of Public Health Sciences. Well, we are very fortunate to have Dr. King here today. And without further ado, over to you, Emily.
Thank you so much, Catherine. And thank you all for joining us today. It's my pleasure to share this work that VHA has been pursuing over the last, the work I'll be sharing over the last about 5 or 6 years to promote workplace violence and harassment reporting at our organization and evaluate how we're responding to that. And the team that has been most engaged in the research work that I'll present today is shown to you here on the screen. It's been a real team effort, as you'll see, to develop a program, implement it across our organization, and evaluate how that's going. And so I'm really looking forward to sharing the program structure and insights with you today. Along the way, we've received funding from the Center for Research Expertise in Occupational Disease, from WeRPN, and through a Health System Impact Fellowship. And so today I will share with you a little bit of background on workplace violence and harassment in home and community care, the program principles and design that we've developed, a little bit about our implementation at VHA, what we've been learning through our evaluation, lessons from that and ways that we're refining our approach. And then as a special guest speaker at the end, we will have Saba Hassan from the neighborhood group sharing how we are partnering with them to explore the application of this approach beyond just our organization. So to start, hopefully not controversial statements here. We care about this project because we want to reduce risk for our providers as much as we can, and to combat the normalization of inappropriate treatment of healthcare workers, which we know to be pervasive across all settings. This inappropriate treatment impacts safety, impacts staff retention, impacts the quality of client care. Working to denormalize that reinforces that we do care about our staff as people, not as just units of care provision. And especially in home and community care, we recognize the higher risk posed to the women and people who are racialized, who make up the majority of our workforce, certainly at VHA. So in terms of workplace violence and harassment, we know that regardless of setting, in hospitals, long-term care, home care, community settings, healthcare workers often experience high rates of violence and harassment, that there has historically been a normalization and toleration of harassment and violence, and that there is a pervasive culture of underreporting. We also know that the workplace violence and harassment negatively impacts both work experience for the providers and patient or client care. In home and community care, especially in homes where we're going to people's private residences to provide care, everything happens behind closed doors. And it is normally just a single individual working alone in the client's home. They have limited information, often about what to expect from the client, the family, and the environment. And we know that about half of clients have some degree of cognitive impairment, and that about a quarter of people with cognitive impairment may display responsive behaviors that can lead to inappropriate actions or harassment or violence. We also know that, as I said earlier, the community-based workforce includes many structurally vulnerable workers. And so against this backdrop, often people, and I'll shift specifically to home care providers now, will choose not to report the violence, harassment that they experience. And there are a number of reasons for that. One of the reasons is fear of negative impacts. If the protective response is to remove the client from the PSW schedule, so personal support workers make up the majority of the home care workforce and are our initial focus for this work. So if the response is to remove a client from a PSW schedule, they lose the opportunity to care for the client. They lose hours of care and income under the dominant pay-per-visit model that we have in home care. And that for some people, these risks are perceived to outweigh the potential benefits of reporting. You've got a quote to the right from a previous study that I conducted saying, I don't report the abuse anymore because I've been losing hours and I cannot afford to lose any more. But that's not the only reason. We know that compassion for clients plays a role, especially where the clients have cognitive impairment and do not really appreciate the impact of their actions. PSWs may choose not to report. They don't blame the client and they don't want the client to get in trouble. Quite the opposite. They have a commitment to continuing to provide high quality care for that client. And then, unfortunately, there's the perception that it's just part of the job. There's an expectation from some that their work would include harassment or violence. And this normalization leads to a feeling that nothing can be done. There is no point in reporting. And so looking at these reasons that people choose not to report, these are all rational reasons given the contexts in which PSWs providing home care can find themselves. And so the approach that we've taken to designing our reporting and response framework is to look at resetting the experience, to look at each of the reasons not to report and how we can turn it around. So there's a fear of negative consequences that outweigh the perceived benefits of reporting. Well, we need a transparent response process, which is going to the extent possible, respect reporters' choices rather than imposing an automatic response that is not what they wanted. And so what we've introduced has a focus on unmet needs, either of the client or of the provider, through a restorative process. Creates transparency if a client is removed from a provider's schedule. Why did that happen? And includes a policy change to prioritize the replacement of hours if a worker and client are separated due to a workplace violence and harassment report. So we're trying to counter the reasons for not reporting. In terms of compassion for clients who may not appreciate the impacts of their actions, make sure that this is non-punitive. The goal of reporting is not to get the client in trouble. It's to share incidents and strategies to inform colleagues so that they can be prepared if they're going in to provide care. And to share these behaviors with supervisors who may be able to help facilitate access to additional supports. The perception that it's just part of the job, so there's no point in reporting. It may sometimes happen, but it is not in the job description. And it is not okay. And reports can be used to improve client care and improve provider safety. There is a point to reporting. Reporting's not worth the fuss. Well, reduce the fuss. The reports need to be quick, and there needs to be an opportunity to share follow-up preferences. It's not just reporting that's not worth the fuss. Sometimes it's the follow-up that people are avoiding. They don't want to have a big conversation about something they've already dealt with. They have skills in managing responsive behavior. They have skills in de-escalation. If they've already managed a situation, they may not want to have that debrief call afterwards. And so allowing people to indicate their follow-up preferences, the amount of essentially time and energy they want to continue to invest in this, is a part of the intervention that we've designed. And we have to make sure it's worth the reporting. So the shift that we're looking to create is that accepting workplace violence and harassment is not part of the job, but reporting it is. Shifting to a culture where people understand that reporting improves safety for colleagues and care for clients. So it is worth doing every time. Core principles for this are that the reporting needs to be quick, meaningful, and not lead to blaming the worker or reducing their income, even accidentally. The response focus is on supporting the reporter and respecting their preferences where possible. And so we've incorporated a trauma and violence-informed approach that recognizes that the same incident could have different impacts on different individuals. And it's the impact it has on the worker that needs to be considered. There is an opportunity to restore client relationships where possible and appropriate, where both parties are open to that. And always a focus on what are the unmet needs of the client or family and the reporter that may have contributed to a situation in which there was verbal aggression or harassment or violence. And reporting violence and harassment is part of the job. So we look at this from a socio-technical system perspective. When we talk about our reporting and response system, the technical system is the most visible part of the system. It's a place to report. So the technical system, we know that the way of reporting needs to be quick, easy, and familiar, with useful information visible to the right people, and to contribute to the feeling that reporting will be meaningful and safe. The social system needs to ensure that reporting is non-punitive, even accidentally, from both a client perspective and a worker perspective. Nobody necessarily needs to get in trouble automatically. That there is a supportive trauma and violence-informed follow-up, that there is a prompt, transparent response process that respects worker choice wherever possible. Sometimes there will be incidents or patterns of behavior which require additional follow-up, but where the reporter preference can be respected, that should be included. The social system should create a culture of collective responsibility for safety and denormalize workplace violence and harassment. And so I'd like to talk you through what each of the elements of this system look like. And I'll give examples from VHA's implementation, but as you'll see, we're working on more. So the reporting needs to be quick, easy, and familiar. Ideally, this is embedded in providers' regular workflows so that it's right there as they're closing out a visit. We ask 4 straightforward questions. Did any of the following occur? Was there verbal aggression, harassment, violence? We use this as an entry point to also say, was there a workplace incident we should follow up on? Or none. And then if there was a something, if the response was not none, then to share the above event was easily managed, challenging to manage. There's a brief space to share a description of the incident and share management strategies, and an opportunity to indicate whether or not active follow-up from the supervisor is required. So just to talk you through each of those a bit. We normally just talk about workplace violence and harassment, but these can sometimes be uncomfortable labels to apply to behaviors. And we know that in some cases, the verbal aggression represents a behavior that PSWs won't feel rises to the level of harassment or violence, but it negatively impacts their work experience, their feeling of safety at work, and it can lead to escalation. And so providing an easy way to report even those uncomfortable incidents is part of creating a more open conversation about the experiences people are having in the home. A core focus of this, by making reporting easy, is to make sure that we are hearing about, if you will, the small stuff. We know that if there is a critical incident, if somebody is severely injured, there are already processes in place to respond to that, and to report outwards to the ministry, to the WSIB. But a lot of the smaller stuff still really impacts work experience and is something that we want to be hearing about and responding to before it rises to the level of injuries. In terms of describing how the incident was managed, this provides an opportunity for the severity of the incident to be reflected in some way, but also for the PSW to reflect their skill in managing the situation. It is common that the extent of PSW's social skills and emotional intelligence is sort of neglected in conversations about their work. But the skills that PSWs develop in de-escalation, in persuasion, are are substantial, and this is an opportunity for that skill to be reflected as well. The describing the incident and sharing management strategies. This provides a way for people to communicate directly with their peers about what it was that happened, what triggers there might have been for that, and how the individual reporting was able to de-escalate the situation, for example. So if you know that somebody calms down when you play their favorite music, if it's always best to give them a couple of minutes and to reset the situation. Small tips like that PSWs have based on their deep knowledge of their clients and their clients' preferences and behaviors can be really valuable to the next person who goes in to fill in when they're sick, for example. And finally, we know that anytime any violence or harassment is reported, our supervisors do need to follow up on that. However, what the selection here offers people the opportunity to do is to say, I want a robust follow-up and I do want to talk to you, or I want a minimal follow-up. And we have guidance for supervisors that we provide in terms of what a minimum acceptable follow-up would look like that would respect the PSW's preference to not spend a lot more time talking about this, while also ensuring that we are acknowledging the incident and that we are providing appropriate support. It's important that useful information is visible to the right people. So something that we have built into our system is that an event which is reported in this form then shows up in the client information for the next PSW who might go in, so that they can see what past incidents looked like, and how the PSW responded. So they can see those peer-to-peer suggestions. Supervisors need to see this information. And so they have a dashboard, which can show them all of the incidents reported by their teams. And there is also an email to specifically trigger care team supervisors, CTSs in VHA's terminology, to go and check on those incidents and to provide them with basic details of what happened, to make sure that they have an opportunity to follow up promptly. And finally, for senior leadership, we have dashboards that we have developed that allow senior leadership to monitor trends within our workforce and to address any concerning patterns. On the social side of the system, we need to ensure that our response is non-punitive to either the client or the worker, is supportive, trauma-informed, and is prompt, and that workers know what's going to happen when they report. To address this, on the left, you will see our response framework, which I will talk through in a moment. It's quite extensive, but it provides guidance to supervisors to follow the response process that will best meet these needs. We also have updates to our policies and procedures that have supported this shift, as well as education that we have provided to all of our personal support worker teams, as well as to all of our personal support supervisors. But to take you through that response framework a bit, the key elements that we're seeing here: if an incident is reported, that can happen by phone, email, or the in-workflow reporting tool. It may be that follow-up is declined. In that case, we have guidance for supervisors on providing a supportive follow-up while respecting the reporter's time and preferences, if possible. If support is requested, we have guidance for supervisors on how to conduct a trauma and violence-informed investigation in a way that, and to specifically look to what kind of support is this reporter looking for? What do they want from me when they reach out? Now, if, as a result of this investigation, it's decided that the client and worker do need to be separated, then we provide guidance for setting the foundation for a new relationship with different parties. that involves guidance on creating safety plans, ensuring that new providers are fully briefed about past incidents and strategies that can be used to manage them, and reaffirming safe care expectations with clients and families in order for us to be able to continue service. If, however, it looks like it will be possible to continue care, that is, if the PSW is willing to go back again with appropriate supports, and that looks feasible for the client and family as well, we have guidance for the supervisors in facilitating restoration of the relationship. This can be as simple as calling to reinforce care boundaries, expectations for a safe work environment, or can involve a more extensive process of facilitating joint or individual conversations between the staff and the client and caregiver to discuss perspectives on what happened, encourage acknowledgement of the impacts of this on the staff, and identify and address unmet needs for support. And as part of this, we do provide a number of sort of suggestions of types of support that might be needed in terms of the clients need behavioral supports. Is the issue with pain management and they're lashing out because they're in severe pain? Or are there social supports that are required? And then for providers, what supports might they need in order to provide care safely, whether it's partnered visits, coaching, additional training, or emotional support to help them cope with what had happened. The process that we presented sort of that kind of frame. And as we were co-designing our response framework with supervisors, personal support workers, including personal support coaches who are peer coaches within our organization, and union stewards, representatives from human resources, best practice and education, one of the things that came out is that supervisors actually wanted more detailed guidance on this. And so we use these sessions to collect what are the best existing practices that our supervisors are using, and then how could we augment that to make sure that the reporting flow process is also meeting the needs of the providers and the clients, as emphasized by our client partner. So after fairly extensive consultation with these groups, we came back to our supervisors and our regional managers and directors with the final version of the response framework and said, is this a process we can commit to? Let's walk it through and see it. Is this what we can commit to doing? And we decided that it is. And so this has been published on our intranet, not just for supervisors, but also for personal support workers, so that people can know what they're getting into when they report and can know what kinds of support they might expect. And that led us to the detailed guidance in this framework. But it takes more than just a response framework to build that culture of collective responsibility for safety and to denormalize workplace violence and harassment. And so there was a real contribution of our education sessions delivered at team meetings across the GTA and even in parks, where the team meetings were over the summer and in parks, to make sure that we were connecting with all of the personal support teams to share this new approach and to make sure that people knew that they should feel free to report and that it would be safe to do so, and that it would help their peers if they did so. And then the collective responsibility for safety is also reinforced by making sure that peers can see what past experiences with this client look like and how to manage them. And so those are the key elements in the socio-technical system that we have designed for workplace violence and harassment reporting, to ensure that it feels like it's meaningful to engage in this process and that it feels like it's safe to engage in this process. So what happens when the rubber hits the road? We did start with an initial pilot with one of our care teams for 7 months with not much workflow integration, but it was the best we could do at the time. And at that point, we found relatively high engagement with the system. 3/4 of PSWs submitted at least one report. A fifth of our PSWs reported some kind of incident in that 7 months. And active follow-up was declined for 60% of the reported incidents. People felt this was quick and easy to use. Everybody who reported believed that they were taken seriously, and the reporting tool was perceived as valuable. And so the PSWs who participated said in their feedback surveys, their anonymous feedback surveys, please do integrate this into our regular workflows. Encouragingly, we did see some signs of culture change as well, in terms of people reporting increased comfort talking about poor treatment at work at the end compared to the beginning of the pilot. And then we have worked to roll this out with all of VHA's personal support teams. So this is over 1,500 PSWs working across a number of regions in the GTA. We provide service in Toronto Central, in Central East, and Mississauga-Halton. So quite an effort to provide the required education to everyone, to integrate the system into workflow where everybody can access it conveniently at the end of every visit. And to provide training to the supervisors so that they would be aware of the framework. And so how's that going? Well, I'm going to focus on the past 3 months. So not the acute implementation phase. We implemented in July of 2024, but how things look after we've had some opportunity for stabilization. And so we are seeing very high usage of the reporting system, partially because reporting is now mandatory. This is a part of the necessary reporting at the end of every client visit. Don't worry though, engagement was already nearly this high in terms of the number of people who reported at least once when it was non-mandatory. Where we do see a difference is the number of support reports submitted by opportunities. For 71% of our visits, and that is about the proportion of in-home visits we do instead of facility-based visits, we do see reports being submitted. Normally, those reports say nothing happened, which is very important. But it means we know that nothing happened if somebody, it is more likely that nothing happened if somebody says none. You may say, what is the point in that? Normally in the past, we've treated an absence of information as an assumption that things are going well. That's really not the case. In many cases, it means people have chosen not to report what happened. By encouraging people to interact with this regularly, they are familiar with what reporting will look like. And they need to choose, if something happens, they can choose to say none, knowing that's not quite right, or they can choose to share, yeah, there was some verbal aggression or there was some harassment. And we'll see in a moment what the difference that's made. So in terms of what are PSWs sharing with us? Well, the majority of the time, the incidents that they report are verbal aggression. Almost 90% of incidents over the last 3 months. Rarely it is harassment, and rarely it is violence. But we are seeing all 3 incident types reported through this system. Normally, 60% of the time, people are saying that this was easily managed. And so if you think about your own experience working with healthcare workers in any setting, the things that we normally wouldn't hear about are verbal aggression that was easily managed. But we are hearing about those things now. We are creating a culture of sharing that those experiences did happen and that they do not need to be invisible. So 60% of those incidents were easy to manage, things we may not previously have heard about, but people are choosing to share. And another 40%, people shared that it was challenging. In terms of requests for supervisor follow-up, active follow-up is requested in only 12% of cases. We know that one of the common reasons for not reporting previously was, it's not worth the fuss and I don't really want the follow-up. Nobody can do anything anyway. So again, in many of these situations where follow-up is not requested, we suspect that these are things we would not otherwise have heard about. Now, when we look at what we're learning from the incident descriptions and management strategies, I will focus on the most common contributors to the incidents that PSWs are reporting. It is less common at the moment that people are sharing their management strategies, so that's still an area to work on. But the most common contributors to verbal aggression that we're hearing are out-of-scope requests. A client will request something that is not part of the care plan, is not part of a PSW's scope, that they are not able to assist with. Resisting care or a refusal of care. Verbal aggression grounded in suspicions leading to accusations of the PSW. Sometimes it is frustration with scheduling. And that did rise into the top 5 potential contributors. And sometimes it's substance use. Clients are not always sober when PSWs arrive to provide care. When we look at harassment, sexual harassment is the most common, followed by racism or harassment related that appears to be triggered by or related to substance use. In terms of the most, and I will pause for a second and say that sometimes there are things that could be considered harassment that people may not be comfortable labeling as harassment. And we would expect that some of the things that come out that get reported as verbal aggression, other people might consider to be harassment, but our focus in our education and in all of our messaging is not that you have to get the category right, it's please share your experience. And so violence, maybe an easier to define one. The most common contributors are resisting care or a refusal of care and doing that in a violent way. Responsive behaviors related to a medical condition. That may be cognitive impairment, that may be pain. And a response to a PSW declining a client's request can also lead to violence in some cases. So those are the kinds of things that we're hearing. Now, I mentioned that reporting is currently mandatory at the end of home visits. And I'd like to show you, I think you can all probably guess in the graphs here, where we made the change to mandatory reporting. It wasn't just that we were receiving more reports, it's that we were hearing about more incidents. And so when people had to make a choice, was this none, was it verbal aggression, harassment, violence? There were more people who were choosing to share the experiences of verbal aggression, and it would appear of violence that they, and possibly harassment, that they were experiencing in clients' homes. So these are things that we think we otherwise would not have heard about. In terms of follow-up, in the vast majority of these additional cases, no follow-up is desired. However, we do also see an increase in requests for follow-up. And that's an opportunity for our leaders to provide support to our point of care staff that would not otherwise have existed if we did not hear about these incidents. And so this appears to have been a very positive change in terms of bringing more incidents to light. So those are the numbers, but what are PSW's experiences of reporting through this system? We conducted interviews with 30 personal support workers. The majority identified as women, 2 as men. As with most of the personal support population, certainly the population at our organization, we see that on average they were middle-aged, although we do have quite an age span, and that the majority identified as racialized. They were also relatively experienced in home and community care. So in terms of PSW's trust in the system, some PSWs reported that they trusted the workplace violence and harassment reporting tool. They liked how it was used. They did find it quick, they found it easy, and they found the system to be responsive and effective when the supervisor was responding in a timely manner. They say, you know, with the tool, it's easier. It's the quickest to report because sometimes calling the office, they don't answer the call immediately, right? So after the incident, when I was already on the streetcar, I sent that incident report. I entered it. So by building it into workflow, we have made things easier and reduced the barriers to reporting. Some PSWs still weren't so sure. They weren't sure if the technical part of the system would work, and so they might use email or the phone to dual report. And some people specifically reported testing the system to see if it worked. And then a few just didn't trust the system. And so there is still work to do in terms of building trust within our organization. Many PSWs are still making choices about what types of workplace violence and harassment to report. So especially where the behaviors related to dementia or other cognitive impairments. We've got one example here. If I do report it, I'd feel bad. I'd feel terrible about it. And so that's a PSW who's still concerned that somehow the client will get in trouble or will be stigmatized if they make this report. And so that indicates an area where we can still work on building trust that this will be a supportive process. Also, if the same behavior happened repeatedly, sometimes people stopped reporting it. They find it repetitive to continue to report. And so PSWs had different reasons for their reporting decisions. Sometimes, you know, they did have varied experiences of leadership support, and if they'd experienced negative or what they did not feel to be supportive responses in the past, they would be more reluctant to report in the future. And we did still see some element of people being afraid that they would lose hours and income as a result of reporting, as a result of an immediate overprotective response to remove them from the client's care. PSWs who were reporting did often report that they reported for the sake of their colleagues, like to provide an awareness of the client's tendencies. And so we see on the right there, yeah, like if it's minor, then probably not if it's my regular. But if it's something major, like hitting or kicking and stuff, then yes, I would report for sure. And maybe one day I'm not there and they'll send a replacement. So at least they would kind of know that this did take place. So just be aware. And I think that bit at the end is really what we were hoping to see, is the idea that if somebody else goes, this is the collective responsibility for safety. This is, at least they'll be aware of what did take place. They're warned. Our supervisors' experiences of managing PSW's reports, we learned about through interviews with 10 care team supervisors. Again, the majority women, with an average of 3 years in the role. And so supervisors who co-designed the framework used it. They found it aligned with their existing practices and useful for decision-making. Hardly surprising because they helped to create it. And they valued the response pathways for identifying external and external support networks. Other supervisors were still struggling to incorporate it into practice. Some perceived it as complex or as unnecessary, and instead they preferred relying on their intuition and previous experience rather than standardized guidance. So what did those responses look like? Well, they would gather detailed information and assess the impact on staff, prioritize mediation over staff removal from clients, and work on engaging the funder early for clinical input and resolution planning if that was required. And then if the supervisor perceived the incident to be severe, which was especially common in sexual harassment cases, there would be, in many cases, an immediate protective response to remove the provider from care to ensure their safety and well-being. And sometimes request funder support to implement additional protective measures. And we see on the right, so immediately once you tell me, I'm going to remove you. And that is a supervisor's instinct to protect their staff and not have them go back into a situation which might present a risk for them.
Hi, Emily. You have about
But that,
5 minutes left in order for us to have 10 minutes for questions.
thank you. So immediately once you tell me, I'm going to remove you. That's the supervisor relying on their judgment of how severe something was. But the supervisor, a trauma and violence informed approach tells us that different incidents affect different people differently. And so the supervisor may perceive the impact of an incident to be different from the reporter. And if there is a mismatch in how they perceive that incident, that might lead to the wrong response. So I can tell you that all of our supervisors are committed to trauma and violence informed care. Always in the care for the clients, that is a factor. But they may not always yet see how to transition that to their leadership practice and have made that shift. And as they are managing all of the various pressures of providing client care, of managing their teams, of ensuring people get seen, sometimes we all take cognitive shortcuts. And one of the cognitive shortcuts is to rely on one's own perception of how serious something was and to determine an appropriate response that way. And unfortunately, that may lead still to some overly protective responses that don't quite align with our framework and that may reinforce some reasons for non-reporting. And so we say at this point that our culture change is a work in progress. We are seeing greater signs of openness to sharing workplace violence and harassment experiences. And we are working on bringing in additional training to support supervisors to adopt trauma and violence informed leadership approaches, as well as care approaches. So we are seeing some culture change. We think that we're seeing it because we are treating workplace violence and harassment reportings as decisions as rational based on the worker's context. We're trying to make it quick, low stakes reporting to make it easier to share experiences, respect their supporters' support preferences, ensure the reporting is of value, and ensure that the most supportive responses are the ones that recognize individual experiences and preferences. So that's a VHA. Can this be applied elsewhere? So I will introduce our guest, Saba Hassan, the Acting Director of Independent Living at the Neighborhood Group. And we are working on partnering with Saba to see whether a version of this could be implemented at the Neighborhood Group. Over to you.
Perfect. Thank you, Dr. Emily, for the introduction and very insightful presentation. I would be very quick. I know our time is limited. So I just wanted to share, good afternoon, everyone. I wanted to share that I read an article, Breaking the Silence on the internet, and I found out it was VHA team who put this together. And that is when I reached out to VHA Home HealthCare, Dr. Emily King and her team, and they were happy to support us with this initiative. What we've done is that we partner. We've been working together since last year, I believe around October or a little bit before that. And as Dr. Emily King explained, our frontline staff work in isolation. And at times they encounter incidents involving with verbal physical aggression or inappropriate behaviors from the clients that they serve or family members. So I thought this is, at TNG, we do have a process in place, as many organizations do. But what I found it very interesting with this project was how quick. And that is when I thought we would like to try a TNG so that the staff can report their concerns very quickly. We use a Liker system. And our staff do have devices and they have the app. So staff can simply click and enter what has occurred very quickly. And that would immediately alert the supervisor and the coordinators that the PSW needs to respond quickly so that the supervisor can get in touch with them. As Dr. Emily King was mentioning, the staff do not like to report because it takes a lot of time trying to call, to leave a message, to write an email. But I found having a button to click on the app is a lot easier for them. And it encourages them to report very quickly because workplace incidents are very time sensitive. So we're trying to remove that, the need for the staff to make multiple phone calls or to leave voicemails and keep waiting for a response. So when we started this project, what Dr. Emily King and her team helped us to do was the process to start, having focus groups first that included supervisors, coordinators, frontline staff, union representative, health and safety. And what we did is that we gathered their feedback of how they want us to support. So their feedback was very encouraging. They thought the process and this project would be very valuable to their time, and that it would be easier for them to vent instead. Once that goes, from their side with a click of button, they're waiting for someone to reach them, and they would have the confidence that someone would be calling them. So currently, what we are at the second stage of piloting this project with a small group of staff. So the way we're doing is that sometimes personal support workers, it can be very difficult and challenging for them to use technology. So what we're selecting is that 3 staff who are technology savvy and 3 staff that might have challenges with technology so that we can get enough evidence of how we can support for those who might have difficulties with technology. So ultimately, this process is being very quick. It's all about ensuring that our staff feel heard, supported, and to work in a safe work environment place. And we look forward and excited to be working with Emily King and her team, improving, and that our staff have a consistent and open process that supports them at the neighborhood group.
Thank you
Sally.
so
Thank
much
you,
for
and I'll
that.
take questions if you have any questions. Thanks.
Thanks.
Thank
I
you very
just want to say
much.
we are delighted to be able to have this partnership with you. And we are open to working with other organizations as well to take what we're learning from adapting to the neighborhood group and to share how that might inform adaptation in other places. So
Thank you.
Thanks,
Catherine, I know
Emily.
you want me to
I'm
stop.
going to jump into the questions
Okay.
right now because the first question we had was this tested out in any assisted living? Did you just do this with your outreach program, or do you have assisted living clients that this was tested in as well, Emily?
So we do have staff who provide support in retirement home facilities as well. And so that does provide that facility-based environment. Their workflows are quite different. And so the notion of a visit that starts and ends is a little more complicated when you're moving between different clients dynamically, based on sort of whether somebody needs a few minutes here and then you can come back to them, and so it doesn't work as well in facility-based settings where PSWs are moving between clients as much. This seems to work best for those home visiting situations where the care is happening in private behind closed doors, which was historically the area where we had the least insight.
Thank you. Is there anything you can recommend for a patient looking at this model, a patient that's in an acute mental health hospital unit that has, repetitive behaviors that are violent?
So I think the elements of our framework, which would be most applied in that situation, would be when we look at the the use of a restorative inquiry process as the foundation for understanding how to move towards safe care. And so that enables us to focus on what are the unmet needs in the situation that may have led to this behavior, and how could we make sure that those needs are met. So we have a very supportive process that can be in place, and that can look at what are the needs on the client side and what are the needs on the provider side. Now, I suspect that you already do a version of that in a mental health hospital unit, but I would say, increasing our focus on that has been one of the shifts that we've introduced through our response framework.
Thanks, Emily. Can you share if there's been any kind of follow-up with PSWs who don't want follow-up? How do you
Like what
tackle
that looks like?
Yeah.
So the minimum follow-up that we can do, we have an email template for that. And we have an email template that we have shared with all of our supervisors that includes some core elements of acknowledging the report and thanking the reporter for sharing that experience, acknowledging that they are not expected to accept workplace violence and harassment, that we are here to support them, that by saying don't follow up for now, they have not, they can still change their mind at any point. The supervisors will still be available to provide additional support if they wish. And so that provides a quick update. I see in the chat, can you share this template email? Sylvia, I can reach out to you and do that, yes.
Emily, did you notice any repetition between the clients and the PSWs when you did the data analysis?
So are we seeing multiple reports for the same clients and multiple reports by the same PSWs? Yes, sometimes there are these persistent issues, and those persistent issues, that's one of the things that we're using our tracking dashboard for, is to understand, can we, where are these incidents occurring repeatedly? And even if PSWs are consistently saying, like, I managed it, I don't need support, sometimes those patterns indicate that there is an opportunity to report. There is an opportunity to go further to see if we can address the roots of those behaviors and to improve staff safety and experience. Sometimes I will share one of the things we found in our pilot is there were multiple reports from a single client by multiple PSWs that didn't say they needed follow-up. But when we looked at it, it was an escalating pattern of verbal aggression or violence because the client was in pain whenever he was moved. And so there was a gap in clinical care, and there was an opportunity for our supervisor, or actually our clinical lead, to follow up with his palliative physician to try to address the root of that so that it would reduce his need to lash at it.
What an excellent example. This may be one of the last questions, and that is this model available in French? And if it isn't, would VHA Home Care be open to translation partnership with our registrant from Quebec or any other registrant?
It is currently only available in English, and we are certainly interested in partnering with other organizations to help support adaptation of this model to other practice contexts. That's one of the things that we're doing with the neighborhood group, and we are happy to work to take lessons from this and to try to share those lessons with other groups to support successful adaptation there as well. This includes French. Whatever your language, if we can provide the principles and some support for concepts to support implementation, we would love to do that. And
Wonderful,
so, yes, I
Emily.
would be delighted to.
We've had a lot of people ask for that email template, so it just won't be one individual. And I'm wondering if it's something you could send to Bettina as a PDF, and then she could share it if you could get permission to do that.
We'll look to those key points. Yeah.
Okay, thank you. And I just want to thank everyone for joining us today, and thank very much our two presenters. And Emily, I think we'll probably be looking at a follow-up. So much interest and so much to learn from the progress that you are making with this model. Thank you so much, and thank you everyone for joining us today.